So I'm Shaun Richards. I'm the Secretary and Treasurer of the Sinclair Lewis Society. And I'm just gonna give some, first of all, again, thank you all for being here. This is such a great turnout. We'll have more of our talks tomorrow, but for so many of us, it's been our first trips here, and everybody's been so welcoming and friendly. And Richard has already said hi to me, who I met last night at the film. So thank you so much. The Sinclair Lewis Society and Sinclair Lewis Foundation are pleased to announce Dr. Michael T. Osterholm as our special guest speaker at our 2025 conference, celebrating 100 years of Lewis's medical novel, Arrowsmith. Last year, Dr. Osterholm posted on Blue Sky that, quote, "Public health is bigger than any one person. There is perhaps no one more qualified to deliver an address for us tonight," and also talk about the continued relevance of the first American novel written about American medicine, public health, infectious disease, and epidemics, Sinclair Lewis's Arrowsmith. Dr. Osterholm, a PhD in environmental health, an MPH in epidemiology, is Regents Professor, McKnight Endowed Chair in Public Health, the Director of the Center for Infectious Disease Research and Policy, or CIDRAP, a Distinguished Teaching Professor in the Division of Environmental Health Sciences for the School of Public Health, a professor in the Technological Leadership Institute in the College of Science and Engineering. I'm running out of breath here with all of these titles. And an adjunct professor of medicine in the Division of Infectious Diseases and International Medicine in the medical school, all at the University of Minnesota, which Dr. Osterholm informed me today is 50 years at the University of Minnesota. So congratulations. In November 2020, the month during which the US surpassed 10 million cases of COVID-19, he was one of 13 public health experts appointed to President Biden's COVID-19 advisory board. And leading up to that, he was involved in every presidential administration going back to Ronald Reagan's. Like Martin Arrowsmith, Osterholm is a well-regarded researcher in the fields of biomedicine and public health. He has over 36,500 citations on Google Scholar, more than 315 publications across numerous prestigious journals. And like Lewis's collaborator on the novel, microbiologist Paul de Cruyff, whose 1926 book, Microbe Hunters, popularized important scientific breakthroughs for a public audience, Dr. Osterholm is the author of 2 best-selling public science books, 2000's Living Terrors, What America Needs to Know to Survive the Coming Bioterrorist Catastrophe, and 2017's Deadliest Enemy, Our War Against Killer Germs, which he describes as part history, part current affairs, and part blueprint for the future. He discusses numerous international public health emergencies, and again, going back 50 years, 20 years with your publications, these are also timely today as well. His forthcoming book, The Big One, Why Future Pandemics Will Be Worse and How We Must Prepare, is due to be released later this year. Dr. Osterholm has also made numerous appearances across various forms of mass media. Throughout 2020 and 2021, he was regularly featured in interviews broadcast on national TV, cable news, and popular podcasts, including his own, the Osterholm Update. And this was, in fact, I'm kind of nerding out a little here, but while I was working on my dissertation chapter on Arrowsmith and watching the news about a pandemic 100 years before that and being quarantined and seeing Dr. Osterholm's face on some of these programs. Dr. Osterholm's experiences, again, are not too dissimilar from Martin's, especially from some quotes here from Lewis's novels, about his campaign of public health agitation while serving as the assistant director of the public health in Nautilus. Indeed, someone somewhere has probably echoed one of the fictional townspeople of Arrowsmith's Wheatsylvania when Martin's trying to get everybody to be worried about diphtheria, antitoxin, by telling him, oh, give us a rest. You got epidemics on the brain. A parallel to another character is Dr. Sandelius, the, quote, soldier of science whose health war on disease was fought in lecture halls across the country, which inspires Arrowsmith to leave the cloister of the laboratory and enter public health. So, our guest could not be more timely. In the US, the sitting president has pulled out of the WHO, the World Health Organization, for the second time in his many administrations. Secretary of Health and Human Services, Robert F. Kennedy Jr., recently fired all 17 members of the Advisory Committee in Immunization Services and replaced them with 8 vaccine deniers or vaccine skeptics. And just today, he's apparently fired 2 more high-ranking aides. So to sort of sum up here, another of Dr. Osterholm's social media posts, specifically about the role of public health experts and professionals, I think is appropriate. Dr. Osterholm says, we're not out here to pick fights, but we have to do our job in public health, and that job is to tell the truth. In keeping with Sinclair Lewis's contagious spirit of educating and promoting the importance of public health, and in light of recent efforts to gag the communication of important health-related information relayed from expert scientists and researchers through government agencies to the public, we need now in 2025, as much as we did in 1925, voices such as Dr. Osterholm's to help keep us safe. So with that, I'd like to turn the floor over to Dr. Osterholm for some brief remarks, and then we're just going to have sort of a fireside chat rather than a keynote speech. So we'll open it up to the audience for some questions, and just leaving the Palmer House, Dr. Osterholm was approached by several locals. So seeing all you faces out here, I'm sure people have questions and maybe just want to say hi and thank you. So I encourage everybody to participate. Okay? Thank you.
Thank you, Shaun. That was an incredibly kind introduction, much more than you needed to hear it, trust me. Let me, before I make any comments, I kind of set some of the groundwork for you about what those comments might look like. First of all, I have been at the University of Minnesota for 50 years, and they're not getting rid of me anytime soon, to the best of my knowledge. So I'll be there for a few more, given particularly what's happening right now in our world of public health. But for 25 of those years, I also spent it at the Minnesota Department of Health. I did both. And one of the moments of greatest pride to me in all my days at the State Health Department was when I actually visited and participated in a meeting at the 87th County Public Health Agency building or courthouse. So I've made all 87 counties in the state. And to me, I think of Minneapolis, St. Paul as one part of this country, but I think of what we call Greater Minnesota as another very important part. So for me to come to a place like this, it's very meaningful and very special. So thank you very, very much. And I can actually remember my exact moments I was here back in 1984 and 85 for the first time. So I appreciate the opportunity to be here. The second thing is that I will tell you there's a parallel here about authors and impact, and we'll get into that much more with Arrowsmith as we get further along. But I I was born and raised in a small Iowa farm town. I was the oldest of 6 kids, and my father was a mentally ill alcoholic whose every sentence was punctuated with his fist. And as the oldest child, I took a lot of those. I understood them very, very well. But what saved me was the fact that my father worked at the local newspaper as a photographer, and the owners of the newspaper was a husband and wife team who were, by the very essence, Renaissance people. The woman who was one of the editors there, bilingual, French and English, and she did one thing I think that hardly anybody at that time, as my childhood, did in Northeast Iowa. She subscribed to the New Yorker. And one day, by chance, I happened to pick up the New Yorker at her house. She was like a kind of the mother of my soul. And I read this fascinating piece by this guy named Burton Rouget. I didn't know how to pronounce his name at first. And it was a whodunit medical detective story. And it turned out that Burton Rouget had written for many years for the New Yorker these stories. And so the next time I said, next one comes, can you let me know? Well, the bottom line was, by the time I had read a year's worth of these, and I was in 7th grade, I knew I wanted to be a medical detective. I knew it. This author did so much to me. And just shortly, I just have to conclude it because it also, I think it says something about fate. In 1996, I led an outbreak investigation in Laverne, Minnesota, in that whole area of southwestern Minnesota, of a condition called thyrotoxicosis. What this is, thyroxine is the chemical that basically is the metabolism chemical in your body. And usually when you have enlarged thyroids, you tend to have a lot of chemical get produced, and you get basically, you could be in 40 below weather with a t-shirt on and sweating kind of thing. And unfortunately, we had a number of people who actually died from heart attacks as a result of this. And no one could quite figure out what was going on because the thyroids on these people were actually shrunken. They weren't big. So why did they have all this thyroxine? Well, we solved it. It turned out that in the meat industry, back at that, just before that time, had discovered that they could make thyroxine for human replacement use by growing it in bacteria, no longer using bovine thyroid harvest. And so rather than basically now very delicately take these thyroids out and put them into one container for making thyroxine, they basically had a condition called neck trimming, where they ran the head on a big spike down an assembly line, and people would trim off 1.5 to 2 pounds more off the larynx, and it had thyroid. And that would go into boxed beef, which would then get made into hamburger. And it turned out that in retrospect, they were eating all this bovine thyroid, which we actually did experiments and showed that one hamburger was the equivalent of one entire weekly replacement dose. So if you had a couple of hamburgers a week, you just kept getting bigger and worse. Well, the reason I tell you this story is because Burton Rouget actually wrote about this as his last story, and I got to meet him. And I got to tell my story of many years between my first move, and it was an amazing event for me, one of the most amazing. So let me just share that from the idea of Arrowsmith and how important that has been. And I read that Arrowsmith in college. I'll be the first to acknowledge it was dense. I was trying to keep track of all the characters, etc., but the more I read it, the more I appreciated and understood just the ability that Sinclair Lewis had to describe those conditions. And I also found that when I read it, I didn't understand those characters like I now understand them, because as I've grown older, I think, am I that character now? Or maybe I'm this one. Maybe I'm that one. And I think that has been a really important story to go back. So I read it in college. I went back, skimmed it quickly over the last couple of weeks just to make sure that I didn't sound too stupid. And I'm here tonight to tell you that this is an amazing opportunity. And I just want to also congratulate you here for what you've done to keep that house and to keep the whole spirit of Sinclair Lewis alive. The fact that there are so many experts in Sinclair Lewis who are here in this audience tonight who have come from all over the country. This is remarkable. What a testament it is to this community. So I just want to say thank you for having me, and I will do my best to answer the questions. Last point of context. As you noted, I have served in every federal presidential administration since Ronald Reagan, where I was involved with the HIV/AIDS Commission. And the Biden-Harris, I was on the transition team for COVID. In Trump 1, I was a science envoy for the State Department. At the State Health Department, I served 2 Republican governors, 2 Democratic governors, 1 independent wrestler as an epidemiologist. For those from out of town, it was Jesse Ventura. Sorry, thank you. And you know, no one can tell you my partisan politics. I mean, I was a private in the Public Health Army, and my job was to do my job and to tell truthful statements to whoever was in charge. And I still will continue to do that, but some of my comments tonight may come off as if I am partisan. I am not. I am helping you to understand the mess we're in.
Yeah, so you talked about coming to Arrowsmith. This has been a common question among a lot of us who are meeting each other for the first time, and sharing how we first came to the novel. That's one of the first questions. So you said you read it in college. You had already decided on becoming a doctor or a medical detective. And I think there's something about not only that pioneering spirit in Arrowsmith, but also this sort of dime novel, detective romance component to it's really sort of idealized there. So what stage of college were you at? Were you pre-med? Were you in graduate school?
Well, first of all, I went to Luther College in Decorah with the understanding that, in fact, I wanted to go on and get a graduate degree in epidemiology at the University of Minnesota. I knew that before I started college. I mean, Minnesota had one of the last remnant programs in infectious disease epidemiology. Remember, in 1975, everybody said, "What the hell are you going to go into infectious diseases for? That's that's horse and buggy days. It's over with." And some of us said, "No, not quite, not yet. Trust me, it's coming back." And in fact, it has come back dramatically. So at the time, I knew I wanted to do this, and I was very appreciative of what I read in Arrowsmith. But you know what? I think Arrowsmith is a required reading every decade of your life. Because one of the things that Lewis captures is the growth or the lack thereof between position, job, location, time. And I think that is by the time you start that book and end that book, you spend a lifetime with Martin. And it is one of those ones where it helps you understand, oh, if I'd only known then what I know now. You know, and how many times have we all said that to ourselves? God, I wish I knew that back then, you know? And I think that this book, at the time when I was in college, I wasn't smart enough or alert enough or maybe just have enough common sense to understand that. And so I think that from that perspective, it really is important to help anyone who reads this book to understand you're not going to get it all right now. You're just not. You're going to get something special. But I promise you, if you allow yourself to go back and read it every couple of years, it'll be a different story every time you read it. At least that's my experience now. And I think that's a valuable lesson in life, you know, where we're all at right now. And so to me, the art of good, great literature is it doesn't just not grow old, but it grows new, even though it's been written days, months, weeks, years before.
Yeah, that's been a common thread with trying to infuse the society and the foundation with some new blood and younger scholars. People sort of talking about this was required reading, maybe for somebody in the medical humanities or traditional medical graduate student, something like that. But a lot of Lewis's work is sort of about something that a 17-year-old, a 22-year-old isn't going to get. So you mentioned this, and then I sort of cut you off at dinner, but we talked quite a bit about Gottlieb in our papers today. And you said that you had your own Max Gottlieb.
Yeah. and this is a story that really, I think, bears telling, because it says something about more than just a book. I had a lot. So I started graduate school in the end of May of 1975. I also got a job at the Minnesota Department of Health as a graduate student worker, because at that time they had one trained person in infectious disease epidemiology, one former undercover agent for drug enforcement agency, and 3 graduate students. And that was the sole sum total for the state of Minnesota. And so I came in as another graduate student, and one of my most proud moments is the fact that when I left 25 years later, we had almost 140 people in infectious diseases, and it was paid for by soft money. It was not paid for by the taxpayer as such. We went out and earned it and brought it in, so the state benefited from that. But the reason I tell you that is because I got so into the work that we were doing there, and this is just as toxic shock syndrome was emerging, and our group got very involved on a national level with toxic shock syndrome and the whole tampon story. And I found school as a major inconvenience. And I had a professor that cared enough about me that the State Health Department building was 3 blocks away from our campus buildings. And this is before iPhones or anything like that. About once a month or two, he'd come walking into the health department, and everybody would quick get on their phones in the hardline phone and say, "Mike, Rex is coming." He was coming to find me and said, "You've not made class this week yet." And he was right. But I was busy doing some important stuff, so I did stick with it. But I said at commencement, and I've said many times later, that PhD was as much his as it was mine. And I owed him immensely for that. And as a Gottlieb to me, he owed that. So over the course of my career, he followed it, and we stayed close, and as a dear friend. And it all kind of came to a head when, unfortunately, a few years ago, he was diagnosed with Lewy body dementia. And he was finally in a memory care center, and I would go see him regularly. And we'd talk, and sometimes it worked, sometimes it didn't. But then I got a call one day, and I'd seen him a couple of weeks before, and it was at that point, it was hard to have any kind of conversation. And his wife said to me on the phone, he says, "I don't think Rex has much time left." And I said, "I'll be over." I went over very early the next morning to this memory care unit, and I sat there, and he just laid there. He had not had any response to stimuli of any kind for the previous 4 days. Hadn't eaten, nothing. And I sat there rubbing his head and talking to him, crying my heart out. And I got up to leave, and knowing it'd be the last time I'd say goodbye to him, and his wife went out in the hallway with me, and we were in this deep embrace when his adult daughter came running out and said, "Mom, Mike, get in here." So we went back in. I'm looking, so what? She looked at me and said, "When you got up and left, he looked at me and said, 'What's he up to now?'" Those were the last words he spoke before he died. And I felt like my Gottlieb not only started my career with me, but it went to the end of his career. And so I can't put in enough positive terms how this one aspect of the book, first of all, mentorships are incredible, but don't expect them to be perfect. Gottlieb was an example of that. There was some real challenges that went back and forth between the relationship. There were days when they didn't talk, they weren't together. But in the end, Gottlieb showed enough to Martin that, in fact, he could learn from that, and he could incentivize himself to be like that. And I think that one of the things that I don't think we think enough about, but I look in this room, there's a hell of a lot of Gottliebs in this room right now. People who can help mentor, who help those who are coming along. And I think that's really, really important. And I particularly look at the age of some of you in this room. And since I'm an old man, I feel like I'm qualified to talk to this issue. Is the fact that my kids really set the tone for me about what I think about the future. When about 5 years ago, they bought me this electronic picture frame that sits on my desk. Every 20 seconds, a new picture of one of my 5 grandchildren appears. And I can be in all these meetings on my computer, all this stuff, and I just keep looking at that picture, and I know, why am I doing what I'm doing? It's not about me. It's not about, a better job or more money or recognition. It's about, what does this mean for my grandkids? And I think in this book, he tried to capture that. And I think coming from a small town, as he did here, his formative years, I think that added to the kind of Gottlieb that he really thought about or talked about and responded to. And so, to me, the characters in the book, I have such attraction to Martin because, in a sense, I'm just as screwed up as he was. But I like to think I accomplished some of the same things he tried to accomplish. But I can tell you that Gottlieb was right there, right with it, because I saw both. And I not only saw both then, but I see it now today. What am I doing to be the mentor that Gottlieb has been to Martin, and what did that mean?
The sort of, part of the narrative arc, you talk about the importance of times and places. And each really step, you really follow Martin's progress in his career, jumping ahead at times, but even from different aspects of medicine, right? From knowing that he wanted to do something research-based to the practical thing of opening a private practice. And there's a real, because of Martin is described as a nobody from nowhere, how he describes himself. Could you talk a little bit more about growing up in a rural area without having to seek out that mentorship, and then maybe a little bit about if there's anything still there, remnants of again this romanticization, especially in the Midwest, of physicians as being not just doctors but also farmers and working their own land, and oftentimes being at the cutting edge of modern implements like cars, if they had to make horseback house calls instead of riding out on horse, or having the only telephone. Of course, this is commonplace in the 60s, but there's still, I think, something about being a first generation or being a non-traditional student and going into really one of an expert specialized field.
I think the theme that runs through for me out of Arrowsmith is the fact that even in a time of discovery was slow. Discovery often took lots of effort to make things happen. Today, we have more happen in discovery. We have more happen in so many aspects of life in one day than we used to have in 1 year. Remember what the world was like before cell phones? Remember what the idea that the internet was some crazy thing that the Defense Department was doing? Remember when medical care surely didn't provide some of the magnificent results it does today. It was also a lot simpler for everyone to understand and to appreciate, well, why am I getting this, or why am I not, or what does this mean? And so it is hard to extrapolate, in a sense, what Martin would look like today. What would he be like if he was a doctor today versus then? But I think that doesn't disqualify him from being a very important role model for today, because in fact I would suggest, and I don't know how many physicians are in the room, if there are any, but the bottom line is that in many ways it's harder to practice medicine today than it's ever been. It's complicated. It's challenging. Again, I will just repeat that we are about to watch the devastation of rural healthcare in this country based on what happened this past week. The payment system issue is going to erode quickly. I come from my small town. We have a hospital. It has been the lifeblood of the community, whether it be because people stay in the town because the hospital's there. People come to work there and spend their money in this small town. And it provides a source of incredible pride to have that service available. Many of these hospitals are not going to make it. Imagine what Martin would be like in a situation like that, where he now is not only challenged by the questions of what does this finding mean or what doesn't it mean, but now imagine him having to watch the closing of your community hospital here. What would that mean? And so I think that I look at that book now and I almost try to be somewhat, for a lack of a better term, bilateral, thinking concurrently about the book and the time, but what does the book mean at this time? And I think it has a life of itself longer than just what it was back at that time. And so just take it for what it's worth for those who are not in the medical area. Life is very hard in medicine right now. And you know, I saw that more, and I know we're over this period, but it has had some lasting effects. I don't think I've ever cried as many tears in my lifetime as I cried with intensive care doctors, with nurses, with emergency room docs during COVID, when you know they were working 30 hours at a stretch and watching people die left and right. That was hard. Well, I think Martin, that's exactly the kind of thing that had he confronted, he would have been a modern doctor, a very modern doctor. And so I think that bridges kind of the past and the current. And again, if you were to go back and reread this book, with just the discussion we just had, I guarantee you're going to have a very different view of the book this time than you did 10 years ago. Just because now you're thinking about it, wow, oh.
I have several different directions to go from that. One of the things you said on a podcast from a couple years ago now, and I think it's just refreshing to
That's what my
hear.
kids tell me. A couple years ago, Dad.
2023, so only a couple years ago. Talking about the complexities of modern healthcare and all of the different interests and parties, it's really about the sort of, I don't know, to use a football metaphor, like you're the goal line. The last person to take it over is that interaction between direct healthcare professionals, doctors and nurses, and patients. And this policy, these laws, this research comes from statistics and comes from all of these sort of faceless, humanless authorities, right? But it really comes down to that sort of the work that doctors and nurses do. I think that some of that comes through in the novel with the researchers and not having a bedside manner, the statistics, or even ideas of taking sort of totalitarian control during epidemics. But I wonder, like, so it's really refreshing to hear that people in public health, people in positions of power, people in these prestigious research institutes care, right? That we're not just facts and figures, that we're not just data and statistics. Something sort of related to that is you talk about incremental increases in scientific work, especially now. But you also, in this episode, you had said it's important to know what we know and what we don't know. Again, patients waiting, frustrated, waiting to hear back from insurance or for a specialist, right? Can lose sight of this, that the experts know and they don't care about the human aspect, that last line. So I suppose that's not really a question, but it's more just an appreciation that that the policymakers and the researchers are thinking about this, about treating people, about caring for people.
Well, let me first of all add again the context from Arrowsmith and think about this situation I'm about to describe to you, and how when you read any number of those chapters, you could see a connection. Here I am now in charge, and I'm taking away all of Martin's bacteriophages, saying you can't have them. They're not in your hands, okay? What would have happened to all those people that lived because he struggled whether to put them out there on a broad base, but he did. And what I'm talking about is that, you know, in my 50 years, I've never seen close to what we're seeing right now happen. On the night of the election, I realized that the public health and vaccine world was in big trouble. And, you know, I'm 73 years old, and I had thought about, maybe slowing down a little bit. And I spent the entire night rereading the 2025 document and realizing that although it was disavowed that this would be what the administration would do, in fact, it was going to be the blueprint, which it has turned out to be. And I wrote an email to our staff the morning after the election and said, well, I'm signing up for 4 more years. This is why. I wrote a piece in the New York Times that came out 2 weeks later and saying, do you realize with Mr. Kennedy as secretary and with the president-elect indicating he was going to let him run wild, what this would mean and happen? And he would take on one of the most fundamental, most researched, most successful interventions of all medicine and public health, vaccines. And in the New York Times piece, I talked about how many millions of people are alive today because of vaccines just in the last 3 decades around the world. And the fact of the matter is that if you are someone who doesn't believe vaccines are effective, or you believe they're dangerous, again, the data don't support that. And what we do is go on data. Mr. Kennedy promised in his hearing that, in fact, his confirmation hearing, that he would not do anything to take vaccines away from people. 3 weeks later, his new head of the NIH and the FDA held a press conference. Without any review at all, they took COVID vaccines away from pregnant women and from newborn children. We know that one of the greatest risk factors for serious outcome in pregnancy today is COVID. And we know the vaccine has been very effective in greatly reducing that. We know that kids today, more kids are dying yet from COVID, unvaccinated as young kids, than are dying from flu. And we would never think of withholding the flu vaccine from young kids. So that was the start. Then he fired, as you pointed out, the members of this National Advisory Committee that are international experts that serve on this thing. Conflicts of interest, all disclosed. It's an amazing organization. Fired him and replaced him with 8 people. He had 17, now has 8, of which 6 are just dyed-in-the-wool anti-vaccine people. And then he went so far as to hold a 58-second video in which he then further went ahead and said, not only are we not going to pay for vaccines for women, pregnant women, but you can't get them, basically. And our group said, wow, we're in trouble here. And we're in trouble because vaccine recommendations in this country are made by one of 5 different societies: American College of Physicians, the Academy of Pediatrics, and ACOG, the group of obstetrician gynecologists. And what they base their recommendations on is what the Advisory Committee on Immunization Practices does. And this is take this body of ongoing information and distill it down to the basic facts of what is this telling us about the vaccine effectiveness, vaccine safety. We monitor it all the time. And the reason that's important is because the payers in this country pay for the vaccines that ACIP recommends. And if they don't recommend it, they don't pay for it. And right now, we're already in the place where there are a lot of pregnant women that can't get the vaccine, even if they can pay for it. But more importantly, they would have to pay for it if they could get it. So our group at Minnesota also basically did a Martin. And we said, wait a minute, this can't stand. So we formed at our little center at the university the Vaccine Integrity Project, in which basically we were able to get support from a foundation headed by Christy Walden. And we brought together a world-class group of people that basically, first of all, we did 8 major focus group activities around the country to find out from public health what could non-governmental agencies do, like us, to address this thing that was happening with ACIP. We then formed an activity where we were in contact with the 5 associations who at first thought, well, this is never going to work. Today, they all are on board. And as I speak, right now, I have 27 people working almost around the clock. We have just completed pulling 16,487 abstracts of scientific information about flu, COVID, and RSV vaccines for the fall vaccine administration. We will have each paper summarized through this expert team, and we are presenting these data to the societies in 2.5 weeks. They will use that as their basis for which to then decide which vaccines to recommend. And although legally there are requirements in some states that you have to use ACIP-based data to make your vaccine recommendations, we're actively involved working to get that changed so that all the payers in the country can use this process and say, we're just going to go around ACIP. We're not going to let him do that. And so, one, I think this is the kind of thing Martin would have looked at and said, okay, what can I do different here? What is it that's got to be done? And do not let creative imagination down for a moment here. Do something, okay? Now, there is one hook, and this one's going to be a challenged one. The American Academy of Pediatrics, several other societies sued Mr. Kennedy and the US government several weeks ago over his declaration on these vaccines. And, you say it was the right thing to do. Well, we have some legal scholars who I have great respect for who said, do you realize there's a good chance you're going to lose this case because of what's happened in the courts to date and how they have favored. If that's the case, you now give Mr. Kennedy carte blanche to take every vaccine off the market, and you won't be able to stop him. Think about that. We're that close. We're sitting on one court decision right now. We just have pulled all the support for vaccines for children in low and middle income countries through a program called Gavi. Pennies, we're talking about pennies per person on the US population. And why is that important? It's not just humanitarian. It is humanitarian, my God. It's soft diplomacy at its best. But you know what? When those outbreaks spin out of control in all these countries, where the hell do they end up? In our country. They come in airplanes. They come in from around the world. So wouldn't we want to put out the flames there and not even let them get close to the house to make sure that the house doesn't burn down? So I think about this because as I reread this, I now had a whole different perspective than I would have 10 years ago, or hell, for that matter, 5 years ago, and now today. So this is the part for me that has been most important with Arrowsmith, is the fact that this book is a brand new book for me, and it's the same one I read years and years and years ago. And I would urge everyone to consider rereading this book now in context of where we're at in this modern world. And you're going to see Martin in a very different light. You're going to see Gottlieb in a very different life. And I think that, to me, if there's a message about the entire long-term legacy of Arrowsmith, it's the fact it's a new, different book as time goes on, and you can never read it too many times.
Thank you so much. That was indirectly answered just about every. I was going to ask you about the Vaccine Integrity Project, about ACIP, and about Gavi, and maybe a little bit about international geopolitics.
Yeah.
And I think you covered all of those. I do have one one thing that you didn't touch on there, and that's you on another recent podcast, this one a couple weeks ago, you had talked about it doesn't have the power of policy. It doesn't have the power of law. And they'll just take these recommendations from, we have questions about junk science then and now. And then that will be, the insurance companies will just say, well, this is the advisement. What is there to do to sort of combat that power of law?
Yeah.
And bring expertise back to its sort of, if not policy making, but policy informing or advising, power to be something equal to that.
Well, first of all, let me be really clear on one thing about the payer. They want to use vaccines because it's a hell of a lot cheaper to use vaccines than to have to treat desperately sick children. It's much cheaper. Cost-benefit analyses have shown that time and time again. So there's no incentive for them to want to spare on the vaccines, okay? It's whether they can do it or not. And we do have this set of laws that have been put in place that to keep people from using radical bases for making vaccine recommendations. They've said you got to use this expert group. But no one ever anticipated this expert group would be co-opted like it is. This is now a corrupted scientific process. Okay, and so it doesn't matter anymore. So we're working on that part. We're trying to find how can we get around things, what can we do, what cases can we make for appeal, and the payers are actually helping us. They want to see this happen, okay? So, you know, they may not want you to get your back surgery, they may not want you to do a lot of other things, but this one they want. And so we're working on that very thing right now. But I think it also points out, as you recall in the book, there was a series, for example, with Gottlieb, went to one institution, basically, you know, that went under, that type of thing. We've always had that experience of challenge. It's just that I don't think anybody could have understood with a toolkit of vaccines, as absolutely powerful as it is, that somebody could actually have the ability to take it away from us. I mean, that I would never have imagined, okay? So, you know, that's like saying we're going to land a B-52 in my backyard. Okay, well, it doesn't work very well, but we're going to try it. So to me, I think that to follow up to your question is the fact that, again, these are different times. They're going to take different solutions. What we can't do is give up. We can't give up. We have a motto at our center. We will bend and we will bend, but we will not break.
So I have one more sort of a parallel, and before opening it up to the audience. You also mentioned recently on your podcast, I had a long drive from Western New York here, so I got to listen to quite a few of your...
You know, if you got picked up for speeding, you would have had cause to say, I couldn't help it.
Well,
I got to get there and get this podcast done.
With the response that I've seen you have so far around here, I think I could have just name dropped you and maybe gotten away with it here in Minnesota anyways. But you talked about a non-health related policy, and that is the current immigration policies. And you were talking specifically about The negative effects that this will have on the U.S. healthcare system with international medical students, recent graduates who are working here to take care of people. The parallel I see is when Lewis writes about race, he writes about race. He's done research on all of the topics that he chooses to write about. He writes King's Blood Royal 2 decades later. But he has this striking scene with Dr. Marchand, who is an Afro-Caribbean who goes to Howard University and then goes back to the fictional Isle to serve his people. So when he's introduced to Martin, Martin sort of says, I wish people would stop showing me things I don't know, right? His real response to meeting a black doctor in the 19-teens is to just say, oh, and shrug it off, right? Thinking of like the Flexner report from 1910 and shutting down proprietary schools, and then shutting down a lot of African-American medical schools and things like that. Taking it back to the sort of patient, only having a certain kind of doctor, only having maybe elite educated doctors, not having people from other countries and cultures to understand all of the multicultural set of patients that they'll have, right? So certainly with numbers and the healthcare profession, but also maybe some of that human touch that will be impacted. None of these things, again, Trump's policies on immigration aren't designed, they have nothing to do with healthcare, but they have everything to do with healthcare.
Yeah, well, you uncovered a lot with this one. Let me just tell you, one of the first things he's referring to is that most people don't realize this, but about a quarter of all the physicians in this country treating you in hospitals are actually here on learner permit, you might call it. It's a visa that's allowed for medical doctors from around the world to come and do their residencies and fellowships in the United States. And hospitals bank on this all the time. It's cheap expert labor for them. And these visas were not granted in July. And so we're right now seeing major shortages in hospitals around the country, and we're trying to address that issue. I mean, it was very short-sighted in the sense of, these are not murderers, etc. These are doctors coming to help to learn. So that part is being worked on right now. Just let me give you an example of another situation. We worry very much about bird flu viruses, avian influenza, and causing the next influenza pandemic in humans. When the virus finally acquires the ability to infect humans and they can transmit to others, that's when you see a flu pandemic. And we're going to see another flu pandemic that could be much worse than 1918. And it's now, right now, the virus has spread into dairy cattle and continues to spread into poultry. And as a result of wild bird contact. And let me just give you an example of this. There are roughly 12,000 people in the state of Wisconsin that are responsible for milking all those dairy cows. And of those 12,000 people, over 90% are migrants who work 24/7 to milk those cows, and for which the livelihood of the farm is totally dependent, because you can't tell a cow, we're not going to get to you this week, okay? Forget it, we can't milk, okay? And right now, we can't get into groups like that because they're hiding. They're so afraid. So from a public health standpoint, if they're sick and ill and could possibly spread the virus, we've been deterred from finding them. I mean, they're underground. At the same time, the farmers are saying, what are we going to do? I've worked a lot of my career in foodborne disease, and I know the companies that are really doing a great job with produce production, particularly in California, the Central Valley, places like that. They're losing all their workers. We're going to see our food supply begin to collapse because these workers are no longer available. Again, if things happen to them, they're hiding. We can't get at, we